The particular areas we've worked on are medicines management, particularly around anticoagulation, and healthcare-acquired infections, and those were the two areas that we focused on. The major progress, I think, is that we've managed to establish good cross-organisational working with the teams from the LHBs and the Trust working together, supported by the 1,000 Lives campaign team. And we've been able to demonstrate that we can take this work into primary care with the cooperation of the GPs, and we've also taken it into nursing homes, residential homes, and in the case of the healthcare-acquired infections, into our prison as well. The nursing homes work has basically used the principles that have been established with the campaign in starting small and then building sequentially through the PDSA cycle work. So we started off by targeting a couple of nursing and residential homes. The nursing teams took the light boxes in, there was an educational package and an audit attached to that, and so we've been able to get most of the nursing homes that we've approached signed up to complete the audit, identify healthcare-acquired infection leads, and we're looking forward to receiving those results very shortly. The impact on the prison work has come because we, as an LHB, commission the health service for Her Majesty's Prison in Cardiff. And this was an opportunity really to take forward the safety campaign into an area where perhaps few LHBs would have the opportunity to demonstrate this type of work. And what we have done is send the nursing team in, again supported by the work by the NPSA and the NPHS, and the work has been the same. The prison have carried out the same audit that the nursing and residential homes have carried out. They've identified healthcare-acquired infection leads, and the work has been very well received. The impact for the patients, I think, depends on which piece of work you're talking about. In the medicines management, what we are hoping to do is raise awareness of the level 4 warfarin commissioning, and so we are working with practices to increase the number of practices that are using point-of-care testing, so that for the patient they will find that they're able to go along to the GP's practice, they will have their blood test taken there, they will be told the result immediately, and they will have their dosing adjusted at that time, as opposed to the traditional way of going up to the hospital, having the blood taken by a phlebotomist and the result phoned through a few days later. So I think there are significant benefits for the patient there. With regard to the healthcare-acquired infections, I know that the practices and the nursing homes have put up the posters to raise the awareness of healthcare-acquired infections, and there's a cultural change that has been undertaken in those places. For the patient themselves, they probably will not notice a significant difference, that the work will be going on behind the scenes. Well, the first half of the campaign for us was largely around collecting the data, establishing the baseline, because, of course, in primary care this was something that wasn't as clear as it was in many areas of secondary care work. So for the first half of the campaign we've been concentrating on that, collecting the audits, and the second part of the campaign then is going to be around implementing the action plans that have arisen from those audits. So that's going to be the challenge. I think that as well as doing the specific pieces of work, we have been quite successful in raising the general awareness of patient safety, and the practices in particular would be very keen to put the posters in place. We have seen some changes in the culture, and we had a fairly good response to the practice of LHB staff audits that were carried out. And again, I think it's a challenge now for the next year to implement the results of the action plans arising from those. The challenge facing the campaign with the reorganisation, I think, is around the key leaders of the programmes in the different areas. We've got a very strong clinical team associated with our work, particularly in relation to the medicines management. There is a risk that those people will be dispersed or move to other organisations. The organisational lead may obviously go, and so there is a risk with that. But I think that the system that we've put in place with an established local committee and reporting mechanisms through the clinical governance committees and then to the boards should mean that the work can be carried through over the next year, even though the personnel may change. The 1,000 Lives campaign is particularly important at this time to the LHBs because with the process of reorganisation it gives the LHBs an opportunity to focus on patient safety and use the skills of the clinical teams that have been developed in this area rather than focusing purely on cost effectiveness and financial issues.